Welcome back to another Mid-Medicine Explainer. Today, we are diving into the fascinating and honestly super complex world of systemic sclerosis. This is an autoimmune disorder that essentially turns the body's own repair mechanisms against itself. Instead of healing, the body just overproduces collagen, leading to this profound fibrosis that can affect everything from the skin you can see to the internal organs and blood vessels that you can't.
To really master this topic today, we're breaking this explainer down into 6 parts: the fibrosis phenomenon, 2 paths, limited versus diffuse, the skin and vessels, CREST syndrome unpacked, internal organ crises, and finally, diagnosis and intervention. Let's get right to it.
Before we even touch the hard data, just take a second to process this. Notice how the taut, shiny skin has literally frozen these fingers into claw-like flexion contractures. It's wild, right? How does a disease turn the body's own structural protein, collagen, into a restrictive shell? This is the very real, visceral impact of systemic sclerosis, and understanding how we get to this point is exactly what we're going to decode.
Section 1. The fibrosis phenomenon. Let's look at the epidemiology and the cellular villains behind all of this.
Systemic sclerosis is a pretty rare but highly impactful disease. We're talking about a prevalence of just 10 to 20 cases per 100,000 people. It hits women about 4 times more often than men, typically peaking right in the prime of life, between 30 and 50 years of age. We also see a higher incidence in African Americans, and as the chart brilliantly illustrates, it primarily splits into 2 camps. The vast majority, 70%, present with limited cutaneous systemic sclerosis, while the remaining 30% face the diffuse cutaneous form.
Now, this pathophysiology loop is just fascinating. The exact cause is a bit of a puzzle, but we know it's a mix of genetic susceptibility, like the HLA locus, and potentially environmental triggers. We've actually seen cases triggered by exposure to things like silica dust, vinyl chloride, epoxy resins, and even trichloroethylene. But regardless of the trigger, notice the vicious cycle here. Endothelial injury sparks a fire. It sets off Th17 T cells, which in turn activate these runaway myofibroblasts. And those cells, they just start churning out massive amounts of extracellular matrix, primarily type 1 collagen. It becomes this relentless loop of vascular injury, inflammation, and aggressive scarring. Section 2. 2 paths, limited versus diffuse. Understanding how and where this collagen actually deposits is your absolute key to diagnosis.
So the most crucial point here is the boundary line on the body, because we classify the disease based on skin involvement. Limited systemic sclerosis strictly restricts skin thickening to sites distal to the elbows and knees, plus the face and neck. It totally spares the trunk and evolves incredibly slowly, over years. Diffuse systemic sclerosis, on the other hand, crosses that line. It rapidly thickens the trunk and proximal extremities, usually right alongside the very first symptoms. Spotting this boundary isn't just a dermatology exercise, it predicts exactly which internal organs are going to be targeted next.
Section 3. The skin and vessels. Let's see how this fibrosis builds visually.
These skin changes definitely don't happen overnight. Initially, patients present with a puffy, non-pitting edema of the fingers. But notice the progression into sclerodactyly here. The skin gets incredibly waxy and tightly stretched. You see that complete loss of normal distal skin creases? The tissue tightening is so severe that it doesn't just cause those claw-like contractures, it literally breaks the skin down, forming these shallow, intensely painful ulcers right over the proximal interphalangeal joints.
And moving up to the face, the fibrosis is just as relentless. Look at the radial furrowing, those super tight wrinkles around the mouth. That causes microstomia, meaning a significantly restricted ability to open the mouth. Inside, you'll often find a shortened lingual frenulum under the tongue, and if you look really closely at the skin surface, you'll spot scattered red dots. Those are matted telangiectasias, which are basically permanently dilated tiny blood vessels right at the surface of the skin.
Now, check this out. This is a nearly universal feature of the disease, and one that can incredibly precede all other symptoms by years: Raynaud's phenomenon. We're not just talking about getting cold hands in the winter. That endothelial injury we talked about causes extreme, pathological vasoconstriction. See the blue discoloration on that fingertip and the stark red line of demarcation? That is critical distal ischemia. If the blood flow doesn't return fast enough, it leads to localized infarction and tissue necrosis right at the fingertip.
Section 4. CREST syndrome unpacked. This brings us perfectly to a classic medical mnemonic deeply tied to that limited variant.
While you can sometimes see it in diffuse disease, CREST is basically the hallmark constellation of symptoms defining limited systemic sclerosis. Let's break it down really fast. C stands for calcinosis cutis. R is for the Raynaud phenomenon we just saw. E is for esophageal hypomotility, where smooth muscle atrophy destroys the lower esophageal sphincter. S is for sclerodactyly, the tightening of the digits. And T stands for telangiectasia.
Here you can literally see the C and T of crest right up close. On the left, calcinosis cutis. These are hard, multinodular, yellowish-white calcium deposits that actually break right through the skin, typically on pressure points like the elbows, knees, or fingertips. On the right, you've got telangiectasia on the mucosal surface of the lower lip. You can clearly see those multiple clusters of dilated blood vessels, which become a major visual cue for clinicians.
Section 5. Internal organ crises. The skin and the visible vessels are really just the warning signs. The real danger lies beneath. Let's dial up the stakes and look internally. The entire gastrointestinal tract is heavily compromised here. Smooth muscle atrophy and fibrosis wreak havoc from top to bottom. In the upper GI tract, loss of sphincter tone leads to severe reflux and erosive esophagitis. In the stomach, patients can develop antral vascular ectasia, often called watermelon stomach, which causes recurrent, hidden bleeding. Moving down, small intestinal involvement leads to bacterial overgrowth causing severe malabsorption. And maybe most dangerously, autonomic neuropathy can cause intestinal pseudoobstruction, triggering massive dilation and pain that can completely mimic a surgical acute abdomen.
But when it comes to mortality, the lungs and kidneys are the prime targets, and they segregate pretty clearly based on the disease type. Pulmonary arterial hypertension, or PAH, is an insidious complication that is 6 times more prevalent in limited disease, presenting with exertional dyspnea and right heart failure. On the flip side, interstitial lung disease and the absolute nightmare that is scleroderma renal crisis are heavily linked to diffuse disease. Renal crisis is terrifying. It features accelerated malignant hypertension and rapid renal failure, and it is a major cause of death.
Section 6. Diagnosis and Intervention. So, with such a devastating systemic profile, how do we catch this and fight back?
Okay, while inflammatory markers are elevated and regular ANA is positive in about 70% of patients, this specific autoantibody profile is your definitive roadmap. It tells you exactly what kind of storm is coming. Anti-centromere antibodies strongly flag limited disease and a high risk for pulmonary arterial hypertension. Anti-SK-cell70, which is also known as anti-topoisomerase I, links directly to severe diffuse disease and lung fibrosis. And if you see anti-RNA polymerase III, that is a massive red alert for the impending development of scleroderma renal crisis.
Since we don't have a magic bullet to just stop the fibrosis entirely, our treatment is fiercely symptom-specific. For Raynaud's, we have to force those vessels to dilate using calcium channel blockers, sildenafil, or even IV prostacyclin and the endothelin-1 antagonist bosentan for severe ischemia. For the gut, we manage the reflux with heavy PPIs, we tackle bacterial overgrowth with rotating antibiotics like rifaximin, and we use prokinetics to try and keep things moving. And obviously, we aggressively monitor and manage the kidneys.
Which brings us to the most critical intervention of all, the one absolute golden rule you have to memorize for scleroderma renal crisis. If a patient presents with an acute spike in blood pressure, you must immediately deploy short-acting ACE inhibitors, like captopril. The goal is to titrate and lower the blood pressure by 10% a day until normal, and crucially, you actively avoid beta blockers. In this specific crisis, ACE inhibitors are the undisputed champions. They save kidneys, and they save lives.
I want to sincerely thank you for hanging out with me for this explainer today. We covered a massive amount of complex pathophysiology, but by utilizing all these targeted graphics and visual breakdowns, I really hope it clicked for you. If you found this high-yield overview helpful, do me a huge favor and hit that subscribe button for the Mid-Medicine channel. Your support is exactly what lets us keep producing and bringing you top-tier medical education. I'll leave you with this final provocative thought. Given that a simple blue, painfully cold fingertip from Raynaud's phenomenon can precede internal, devastating fibrosis by literally years, how many patients out there right now, maybe even sitting in your waiting room, are unknowingly holding the very first warning signs of a massive systemic storm? Keep your eyes open, always look at the big picture, and we will see you in the next explainer.